Welcome to Ortho Insider, the Canadian Orthopedic Association's podcast that goes behind the scenes of orthopedics in Canada, or in this case, internationally. Today we have two very special guests, Dr. Kevin Bozic and Dr. Sukhdeep Dulai, and they are joining us and talking about wellness. Dr. Bozic is the Chair of Surgery and Perioperative Care at Dell Medical School in the University of Texas, Austin, and has an MBA from Harvard Business School and is the current president of the American Academy of Orthopedic Surgeons. Dr. Dulai is a professor in the Department of Surgery at the University of Alberta and a pediatric orthopedic surgeon. She is a founding member and past president of the Canadian Pediatric Orthopedic Group, now known as CPOS, a former director of the Canadian Orthopedic Foundation, and a current president-elect of the Canadian Orthopedic Association. So thank you both for being here today.
Thank you for having us.
Our first question we like to ask everybody is, what is your origin story? How did you get into orthopedics? Maybe Dr. Bozic?
Well, I probably have a very typical story in that when I was 13 years old, I broke my arm while walking my dog and was introduced to an orthopedic surgeon who I looked up to, and I actually decided at the age of 13 that I wanted to be an orthopedic surgeon. So I decided that before I decided I wanted to be a doctor or go to medical school. And I went to college to do biomedical engineering with the idea in mind that I would go into orthopedic surgery. So I was pretty tunnel vision all the way through in terms of what my career path would be. And it's worked out well for me, and I've enjoyed a very rewarding career, as I'm sure both of you feel the same.
Absolutely. So, sorry, tell me more though. At 13 years old, you had such a big impact from an orthopedic surgeon that you decided to do that. What is the story behind that?
Yeah, I come from a family of engineers going all the way back. My grandfather was an inventor and invented the air brakes for trains and was partners with George Westinghouse. He was from Serbia. And so long lineage of engineers, and I was interested in engineering, but then having that experience in applying engineering principles to the human body and it was really exciting for me. So I kind of locked in and said that's what I want to do for a career.
Amazing. And it's so interesting that you wanted to be an orthopedic surgeon before you even wanted to be a doctor. That's pretty cool.
Yes, yeah.
Dr. Dulai, same question. How did you get your start?
A little bit different. To be honest, growing up, I did not want to be a doctor.
Yeah.
I thought I was going to be a lawyer. You know, my parents said, yeah, you love to argue, so that seems to be about right. And then I was, before starting university, I had a teacher that I really looked up to who said, you know, I don't think you really want to do law. And I really did love sciences, and I thought, you know what, I got interested in physiology, and I thought, okay, I'll go do a physiology degree. Still no idea what I was going to quite do with that. And I was in my undergrad. I was taking my courses, and I thought, yeah, you know what, medicine seems like a good choice for me, and I'll do that. I went into medicine, and then thinking I was going to do something with children. I really had decided that for a while, that I wanted to do something that worked with children. And so I started medical school, and at the beginning of our medical school, they asked us about, they assigned mentors. It was a very informal thing, but basically someone you could go and shadow if you were interested in a particular area. And they said, do you have any areas to request? So they had a list of people who had volunteered and what their specialties were. And so I chose I said, well, I would either like a pediatric surgeon or an orthopedic surgeon, because those were the two surgery options that I thought might interest me. I had at that point thought, I probably want to be a surgeon. And I went and followed a tumor surgeon, and the rest is history. You see your first surgery and you're hooked, and you just think, oh my God, the difference you can make here is incredible, right? Yes. And even though I saw an arthroplasty, and I'm a pediatric surgeon now, an anti-arthroplasty person, in children, of course.
Yes, right.
But it was enough to say, wow, what a profound impact you had on a person's life. And then I ended up in pediatric orthopedics because I did an elective with a pediatric orthopedic surgeon, and I had already told you I had thought I would end up working with children, and it was such a experience of, one, seeing amazing pathology and doing amazing things, but also an experience where I was treated with such respect as a student, and a positive experience that made me want to do more. So that's kind of how I headed that way.
It's a great segue because we're talking about wellness, and tell me if this is true, but my perspective of pediatric orthopedics, it is genuinely kind of like the kinder, gentler orthopedics. And people oftentimes will say, they have a wonderful experience on peds, right? And so what does that mean to you? You said that you had a respectful environment and things of that nature. Like, what does that mean to you? Because that's a major part of your platform as the incoming COA president.
Yes, yeah, that promoting wellness and initiatives that help to support surgeons in their practices in Canada is part of my mandate, so thanks for mentioning that. I think, when I talk about that experience being respectful, I think it's about, feeling seen and heard. And, I was just a medical student, and it was, between my second and third year, so preclinical, and really, virtually, well, I wouldn't say virtually nothing, but you can't contribute a lot at that point. But from my perspective at that time, that's what I thought. But the surgeon I worked with really, valued my presence and made me an integral member of that team, and along with educating me, obviously. And the fact that I felt seen, I felt heard, I felt like, even though I couldn't say what you should do with a patient, what I did say was appreciated. Yeah. And I thought that, left a positive impression on me. And the other thing is, I just saw that they were happy doing what they did. And that, I think, when people say pediatrics is a kinder, gentler, and I don't want to own it because I'm sure all orthopedic surgeons are happy in their own practices, but we do like to say we're kinder and gentler.
I would agree.
Yeah. And who knows what's the chicken and what's the egg? Yeah. Does pediatrics attract that personality that is more conversive with children and that sort of thing? Or being in that setting, does it encourage that? Maybe a bit of both, I would say.
Yeah. No, it's interesting. And Dr. Bozic, you're a leader in value-based healthcare, and some people might be thinking, well, what does value-based healthcare have to do with wellness? But in your inauguration speech as the AAOS president, you mentioned administrative burden and bringing the joy back into our work. Tell us a little bit about that and how that links to value-based healthcare, and what is value-based healthcare?
I'm glad you brought that up because I think that some people, when they hear the term value-based healthcare, it has this strange connotation, like some mythical, unachievable thing. We can't do that in Canada, or we can't do that here. And really, the term value-based healthcare was coined by Michael Porter and Elizabeth Teisberg in their 2006 book, Redefining Healthcare. And it was defined as a framework for competition based on value delivered to patients, where value is defined as the health outcomes achieved from the patient's perspective per dollar spent to achieve those outcomes. And what I've learned through my work in that area is essentially what you're doing when you think about competition based on value. It's kind of a framework and a mindset for aligning our incentives with those of our patients. And not everything we do in today's world aligns our incentives with those of our patients. Sometimes those are at odds. And the value framework is really just meant as an opportunity to align our incentives with those of our patients, which brings joy because then, as you were just mentioning, as we do things that benefit the lives of our patients, it benefits us and our practices.
So thank you for that, because I think you're right, there's a lot of misconception of what that is. And even when I first heard it, admittedly, I thought, oh, is this like a fancy cost effectiveness technique? And it's not really, it's actually completely different than that. Can you mind explaining that a little bit more?
When you think about value, it's really an orientation, and I always point out that you create value not by reducing the cost of healthcare or improving quote unquote quality and safety, because if you think about value as the health outcomes achieved per dollar spent, unless you improve health, doesn't matter how much money you save or how safe and effective your treatment is, unless you improve health, you have not created value. And so value is about improving health, and it just so happens that health is inherently less expensive than disease.
Oh, that's interesting. So tell us more about that.
Yes, so again, people think, well, the way to improve value is by reducing the cost of healthcare. It's by creating health. And so everything that we do, whether it's making a decision about a treatment option, an operation, whether it's hiring a partner, whether it's purchasing a piece of equipment, whether it's entering into a contract, the mindset is, how is that going to help me improve the health of the people that I'm charged with? And sometimes that means making different decisions about treatment, or about how we communicate with those people, about who is on the team that is needed to be able to help improve the health of those patients. Because as we all know, our health is in part affected by the health care that we receive, but probably 85 to 90% of our health is determined by factors outside of the healthcare system. And so in order to improve health and improve value, we've got to think about how we incorporate those non-medical factors into our approach to improving health.
Very interesting you said that, because, you know, on the matching that to wellness, actually, it's also been shown that patients' health is linked to the wellness of their healthcare providers, so physician wellness. And so investing in things that help to improve physician wellness, like reducing administrative load and those types of things, actually has been shown to improve patient outcomes. So it's not just saying, oh, you know, we want to just take better care of the doctors. We want to take better care of the patients by ensuring that the doctors are well positioned to maintain healthy lifestyles, right? And maintain a wellness perspective. And on top of that, you know, it's been shown to actually reduce costs if you do that.
Yeah, I wanted to pick up on that and say, when we think about the term burnout, it's often framed as a chronic stress response, like we're working too hard, we're overworked, we work too many hours. And in reality, we trained in an era where we probably worked more hours than we work today. But the things that we were doing were aligned with what brings us joy. And so I think about moral injury as a systemic misalignment between the burden and the purpose of our work. The purpose of our work is to improve health and improve lives, and the burden of our work in today's world is a lot more focused on, as you mentioned, the administrative burden. So the reason why I like the value agenda is because it realigns what we're doing every day with improving the health and the lives of our patients, and gets us out of that sort of hamster wheel, gerbil race that occurs in today's healthcare system.
Having said that, there is a component of overworking as well. I agree with you, what we're doing does matter, but you know, people's lifestyles have changed over time, and even the burden in hospitals. You know, I can say in my own pediatric hospital, if you go back 30 years, the number of after-hour surgeries they were doing because of the population they were serving was much less than what we're doing now, right? So that might not be true in a major trauma hospital in the United States, but I can say from my own perspective, you know, orthopedic surgeon on call at one of the children's hospitals now would be going in after hours a lot more than they were before. So even if you say, well, we were working those same hours before, you know, the impact that it was maybe having on your personal life isn't the same as it is now. But I totally agree with what Dr. Bozic said about doing meaningful work is less likely to cause you, to lead to exhaustion or burnout than doing work that you don't find meaning in, and that's that administrative load, or even, you referred to moral injury, the fact that, in Canada we have these wait lists that are just incredible. Obviously exacerbated by COVID, and that mismatch of trying to provide good care for your patients and not having the ability to operate on them in the time that you think, and has actually been mandated on an official level in terms of, the PCATs and ACATs, not being able to do that causes you distress as a healthcare provider, as a physician, a surgeon, because that patient is suffering and you could do something about it, but you don't have the ability to do it because you don't have control over the resources.
I just wanted to follow up on that. I think I agree with you, and I think that what I push back on is this idea that what we really need to do to address this problem of burnout is improve resiliency amongst clinicians. And we're a very resilient bunch. Yeah. And so it's not about the individual resiliency of us, it's about the system.
Yes.
And the system has to be realigned in a way that aligns the purpose of our work with the burden of our work. And the example I'll give is in our, what we call our integrated practice unit, which is set up with some physicians, but a lot of non-physicians that are involved in managing the total health of the patient. We opened our practice in 2017. There are about 37 members of the team, which includes clinicians, it includes social workers, it includes physical therapists, chiropractors, people that are skilled in financial management, other things. We have had exactly 2 people leave the practice since 2017. And they were both because their spouses relocated. And so how do you maintain that level of engagement and that low turnover? It's by having a practice where our incentives are aligned with those of our patients, and everybody is waking up every day doing the things that they love to do. Everyone is operating at the top of their license, and they feel rewarded. Again, what motivates us as professionals: mastery, autonomy, and purpose. People want to be good at what they do, they want to be left alone and given some autonomy, and they want to feel that their work is created to something more than a higher purpose. And so I truly believe that by aligning our incentives with those of our patients, it reduces burnout, and I think we have the evidence for that in our practice in Austin.
May I just ask really quickly, so you guys touched on wonderful points. How did this happen? How do we lose control, and how do we lose our kind of moral compass, so to speak, and how did we lose alignment? And the second part is, then how do we get that back? How do we regain control? How do we realign?
That is exactly why I chose wellness as my mandate, to be honest, because going off of what Dr. Bozic said about this idea that why don't people just be more resilient, plan your holidays, go exercise more, that sort of thing, putting it on the individual. But, surgeons, or orthopedic surgeons especially, are people who, have done a lot of stressful things in their life to get to be an orthopedic surgeon. Right. They know how to manage stress, right?
We're inherently resilient.
Exactly. And so while teaching people, and I went through phases where I was going through my own wellness journey of, let's do some laughing yoga, and sure, there's value to laughing yoga. I'm not saying there's not, but it doesn't solve the issue that we're in. And really, I think with this Canadian Orthopedic Association, hopefully we're able to start delving into some of the higher level issues that are causing, the administrative burdens and the issues causing moral injury, like the long wait list, and provide some, national guidance on, these are the limits of what should be able to be expected. And beyond that, if a health service wants to institute other things, then they have to put the resources in so that burden isn't put onto clinicians, right? For example, I'll tell you, my own health service, they brought in a provincial electronic medical record. I'm not against the electronic medical record. I think it does facilitate patient care. But the problem is, we weren't actually given sufficient resources to ensure, number one, that it didn't interfere with efficiency of patient care, and number two, it gave us an extra administrative burden without offloading any other burden. So you just added it to everything else. So you added the hours of extra, entry time and managing other things they wanted you to manage that previously clerks or nurses were able to do, but now they mandated, no, the physicians or surgeons had to do it themselves. So I think, if we can at least as a national organization say, this is what we say, then people have something to go to their local, health services or hospitals with, to say, the national body is saying this based on the evidence, and we want to demand that we get that support, right? And the COA hopefully can help with that.
I think I agree with those points, and one of the solutions, I'm very bullish, by the way. I believe that there is a path towards a more sustainable healthcare system that improves lives, including the lives of clinicians and patients. And it's going to require us to step up and be leaders instead of complainers.
Yes.
We have a lot of what I call problem pointer-outers, and we
Yes.
need more problem solvers. An example I gave yesterday, Pierre did a very nice sort of global symposium on public health systems, and the common theme was these wait lists. We came into an interesting environment when I came to Austin. We had, I guess might be equivalent to what you have here, in that we were, our county health district, which is our unfunded population, there was a 400-day wait to see an orthopedic surgeon. And within 6 months, we got that down to 1 week, and it wasn't by spending more money or doing more visits with orthopedic surgeons. It was by having non-physician clinicians calling these patients and saying, how can I help you? And some of them, the problem could be resolved over the phone. Some of them it was by, prescribing Advil and an exercise program, and some of it was by coming in to see the team. But we have a very physician-centric healthcare system, and so the vast majority of people that have a musculoskeletal complaint do not and should not see an orthopedic surgeon. It's not necessary. We're overqualified for that, and it leads to burnout, because we're now trying to solve problems for musculoskeletal issues that have to do with lifestyle choices, could be weight management, could be chronic pain, and we're not the best equipped to do that. There are many other people in our healthcare system that are better equipped to do that, and we could actually be having those people bring their skill sets, function at the top of their license, and us managing the patients who are appropriate to talk to an orthopedic surgeon. So I think it starts by creating a workforce of musculoskeletal clinicians and a musculoskeletal medical home, if you will, that doesn't rely on the orthopedic surgeon being the bottleneck.
But no, it's really interesting you bring that up, because as a prime example that I have experienced, just to show people that this is not some pie in the sky thing, is that actually based on your value-based healthcare system at my hospital, St. Paul's, we instituted exactly what you said, right? So I'm a shoulder surgeon. Our previous wait list to see a shoulder surgeon was like 3 years. It was ridiculous. And we worked with our physiotherapists, so non-physician allied health professionals. We worked with them, trained them up to be shoulder screeners essentially, and provided them a one-stop shop of getting diagnosed with either operative, non-operative shoulder problems, and if they're non-operative or if they're operative, giving them the exercise program to help them right then and there. And our wait list went, within this project, within 1 year, went down from 3 years down to 3 months.
And that's less expensive. It really is meeting the patients where they are in their needs, because those people are much better at talking to those patients about their shoulder pain and what they can do to manage it than you are, I would venture to guess. And then that frees you up to do the things that you're good at and are necessary.
And it just brings more, as you mentioned, like joy to my practice, because I'm now seeing the patients who are operative, who I can really make a difference in. And this was your immersive program that you have at University of Texas Austin, right? So we have 2 of our physicians who've gone through that, and it was an Ember project. So it was real life and really excellent.
And I would ask Dr. Dulai, because I'm not a pediatric orthopedist, but I would imagine I always feel bad when my neighbors call me and say, my kid has flat feet, who should I see? And they end up going to the orthopedic surgeon. I think there's probably people that didn't have 14 years of training on your team that could help those patients and probably contribute to your wellness and the wellness of the patient.
Yeah, fortunately in Canada, you need a referral from somebody to see an orthopedic surgeon, which is slightly different, I think, in the United States. So some of that gets filtered out, but we do definitely see a lot of flat feet and toe walkers and things, and sometimes we need to see them. And but you're right, a lot of times it could just be counseling. And There are several initiatives across Canada where, people are trying to develop programs where alternate providers could either screen or even manage the patients that after some training that don't actually need to see a surgeon. That's true, for some hip care programs or even some of these primary, pediatric limb complaints. And people are working towards more of those. We've incorporated at my center nurse practitioners as a key part of our programs to do some of the visits that we feel, okay, you don't need to be seeing an orthopedic surgeon, you just need to be seen to make sure there's not an issue. If there is an issue, for sure you'll be seen by an orthopedic surgeon. And that has helped to offload it. I think it goes back to what Dr. Bozic said about, working at the top of your skill set, because that's where you get the most reward, right? And you feel the most purpose. And doing meaningful work is rewarding, and that's not what leads you to go to burnout. And so if you can get the other people to do the things that they can do and you don't need to be doing, not only is it good for you, but now your time is going to be used more efficiently so you can actually treat more patients, which is part of our problem in our health system, right? Like we have humongous wait lists, not only for surgery, but also even just to get in to see an orthopedic surgeon. In many cases, like you were mentioning, your shoulder clinic, the same is true for so many different clinics around the country, and I'm sure around the world, right? But using models like both of you have suggested is how we can kind of reduce that so that the people who really need to see the orthopedic surgeon see the orthopedic surgeon in a timely fashion, and the orthopedic surgeon is happier doing what they really, are the best at doing, and the patients get a better outcome.
On that point, I think that, imagine the stress and distress for those patients that are referred to an orthopedic surgeon thinking, oh my God, am I going to lose my arm? Am I ever going to be able to function again? When in reality, a simple conversation with a musculoskeletal clinician could reduce that anxiety and distress, take the orthopedic surgeon out of the equation. Yeah. One other thing I'd like to say on the solution side of things is I'm very bullish on potentially the applications of artificial intelligence to reduce some of the administrative burden. I think right now, as of today, in June of 2024, AI has been overhyped in terms of the true applications and benefits that we've seen. But a good example would be the ambient microphones that can record a conversation and generate an office note and do the billing, which again allows us to sit across from the patient, have a conversation with the patient, reassure them, and someone else to be doing or a computer to be generating all of the administrative burden that's required to complete that visit and bill for it. And so it's somehow matching up what we love to do and what our patients want us to do, and take someone else taking that administrative burden away from us. And I think there are probably many, many opportunities to use artificial intelligence to do that.
So you both have mentioned it now, and it's creating alignment within a team. And especially in Canada, it's difficult to do that because there's so many competing interests between, physicians and, for example, nurses and anesthesiologists, financial things and job satisfaction things. As an example, in my OR, we have a lot of new nurses. And so sometimes we get the cardiac nurse doing an orthopedic case. How do you solve that, and how do you create better alignment within a team?
You want to start? Pediatrics is a very good example.
To be honest, we had the same scenario, and we do still at our hospital in terms of, you don't know which nurse you're going to be getting every day in your OR. We, have tried to do two things. One, we try and make the pediatric orthopedic OR the most rewarding and pleasurable experience for the nurses to be in, so that it's someplace they want to be working, they want to come back to, and that's not done by anything hard. Treat people with respect. Include them as a member of the team. Value their work. And that should come naturally. And I think people, when under stress, they forget those things, and that's understandable. But those things make people want to be better at what they're doing and want to be there. So that helps the experience. I think that in terms of, building the team, you want to try and encourage people who are interested. So, taking that time to give them that little bit extra, and that'll pay you back in leaps and bounds.
Positively reinforced.
Absolutely, yeah. And it's not, I get that we are in a situation where some things are out of our control, and that is not a good feeling, and that also leads to people going into burnout, right? A lack of control, especially when you're responsible for patient outcomes. But some of it, by making it a great place to be, you can attract the people you want.
And I think those are excellent points. That if you step back to first principles, you say, what are the skill sets that you need to manage the conditions that you treat? So if we look at musculoskeletal disease, illness, injury, you need people that are skilled in lifestyle modification. You need people that are skilled in many cases, weight management. You need people that can teach people to be activated, whether it's doing an exercise program or some other aspect of their life. And then you probably need a few orthopedic surgeons, but not as many as you'd think. And so if you back up to first principles and say, what do we need to treat musculoskeletal? Put those people on the team, allow them to do what they're really good at, and then the ultimate sort of what brings us all together is focusing on the health of the patient.
Yes.
And so again, I use that word health intentionally because we always say focusing on the patient, but we're all patients, right? We all have the opportunity to improve our health, whether we define ourselves as sick, which is now I'm a patient because I'm sick, versus I'm a human being, I have an opportunity to improve my health. What are the people on the team that we need to do that? So on our team, we have dietitians, we have behavioral health trained social workers, we have physical therapists, chiropractors, and we have some orthopedic surgeons.
The other thing you guys both talked about too are systemic changes to impact individual issues, really. So we had Dr. Andrew Fury, who's our Premier of Newfoundland and Labrador, and he says the same thing as you. He says, and can you remind me of the word you said, like silent complainers or something along this?
No, I just said problem pointer outers.
Oh, sorry, problem pointer outers. Yeah, so he kind of says a similar thing, and he says, if you're going to be a problem pointer outer, don't just sit in the surgical lounge and point out problems. Take an active role, take advocacy, like you have both been doing. So, do you have any tips for the average surgeon like myself out in the community to do that?
I would say that in general, I encourage people on my team, if they identify a problem, come to me with at least one solution. And don't tell me that, I've identified this problem and there's nothing we can do about it. The first thing I'm going to say to you is, so what do you want to do about that? How do you want to address that? The answer is never going to be easy. It's never going to be, it's always going to be multifactorial, but it forces us to put our problem-solving brains on. And I truly believe that as physicians, we are in the best position to solve the problems that each of our country's healthcare systems face. We are better positioned than politicians, than insurance companies, than administrators. We are the ones that interact with every aspect of the healthcare system. Nobody else does that. But it requires us to step up and act like leaders and problem solvers and not victims.
I couldn't agree more with what you said. And, it's interesting. I heard a psychologist talk once, and they said, if we have one negative experience, we're likely to tell 10 people about that negative experience. However, in order to share a positive experience, on average, you will have to have 10 positive experiences before you will share one with one person. So that saying of, how, they say the rotten apple spoils the bunch. And I think, that kind of relates to that. And if you think of our environment right now, where, people do get discouraged, or they don't feel like they're best positioned to be doing their best. I'm sure we all have had the experience of, going in and people complain, and they get to the mode of complaining about everything. And then you listen to it and you start getting discouraged yourself,
Yes.
And I 100% agree. I once I heard that, I took the tact of, if someone would come to me and say something negative, I would try and find something positive to say right in response. It doesn't always happen. I'm not going to say I'm the happiest person at all times, but to say you know what, okay, let's look at it from a different perspective, and if they don't come to me with a solution, I'd say, so how do you think we could do that differently, or how do you think that can be done differently? Because that is toxic to have that where people are only coming with problems, and it really handicaps leaders, right? Because all they're seeing is the downside of any initiative. Whereas, if you have to start thinking about solutions, you can see, okay, why certain things are limited and where really the viable options lie, right? And as you think through that process, then you also have some more acceptance of, okay, in reality, our viable options are limited to this, not what I originally thought, right? So that is so important that, and I also totally agree that, medical leaders have become, at least in the health systems that I'm familiar with, have become in terms of physicians and surgeons, the minority compared to either administrators or nursing administrators or those types of things. And our voice is not heard as loudly anymore. And that I think is a big piece of why things are have gone in a direction that ends up putting us in a bad position.
Yeah, and I would argue, I agree with that, and I would argue that that's our fault, and it's because of the way that we've approached. So we've gone in general, like I can't speak for Canada, but in our country, the things that we focus on as a professional organization is the declining reimbursement for professional services for clinicians, which is a problem and a concern. But when you go to someone who's charged with, managing a budget or creating a sustainable healthcare system, and you say, well, the biggest problem is that we're underpaying physicians, and that's the problem that we need to solve for, they're going to say, thank you very much. Now let's go find someone who can help us solve the problem, because that's not likely to solve the problem. And to your point about, the mindset, I have a little sign on my desk that my leadership coach gave me that says, assume good intent. And so when someone comes to me and is, here's Adrian in my office whining again about his OR time or something, I'm rolling my eyes, I'd say, assume good intent. There's probably a reason why he's doing that. He's frustrated. There's probably, my coach calls it getting up on the balcony and looking down at the system and saying, what's causing this problem, as opposed to getting frustrated by it. And so I think that's something that I have to always encourage myself to do.
Yeah, I think, I'll give you an example. At our pediatric hospital, it used to be that OR time was assigned to surgeons by an OR management committee. And we were finding, within the orthopedic group, we were having a lot of trouble kind of managing the wait lists, and even kind of illustrating that there was a definite need that when more OR time was going to be allocated, that orthopedics had a very good case for that. And so, we went to management and we said, what we would like to do is, we don't want to be micromanaged. We would like you to assign the OR time to orthopedics, and we ourselves will figure out how that needs to be distributed and can be most effectively used, so that we could maximize utilization, right? And to get the cases done that needed to be done. So all credit to them, they agreed with that. They said, we're happy to do that. And, obviously we'll review results, 6 months down the road to see if this is working or not. And I'm sure many health authorities work like this. In our health service, they look at utilization of your OR to determine when more resources are available, whether or not, are you using what we're giving you? Is it actually warranted to give you more? Or are you not effectively using what we're giving you? And even though you have bad wait lists, you're not going to get more because the resources aren't being used effectively. By saying we're going to take ownership of that problem, and we're going to solve it within our own group, and them allowing us to do that, our utilization improved to the best amongst all surgical specialties. And yet our wait lists were still humongous. So the next round of resource allocations, we had positioned ourselves to be given more resources to help us more effectively manage those patients. But instead of waiting for them to come to that solution, we knew what the solution was, but we had to own it ourselves, right? And have the ability to do it. Yeah. So once we said, okay, we think we know how to do this, but can you let us do it? And they let us, and our chief, saw that, and even then encouraged other subspecialties to follow our model, right? Amazing. And not that we solved every problem, but it's a micro example of how you can solve problems if you take the ownership of it and say, we're willing to try to do it ourselves.
I love that. That's amazing. I mean, thank you both for such an incredibly open and engaging discussion. That was incredible. Before we sign off, we always ask, is there anything in your professional, personal lives that you'd like to share or get out there for the listeners? Dr. Bozic?
Well, I'll just say that I think we have an incredible opportunity. I always tell my team we are practicing in the glory days of medicine because we have the opportunity to step up and address challenges that I'm sure over the decades there have been different challenges that exist, but both of our healthcare systems are facing enormous challenges, which creates enormous opportunity, and it requires us just to step up and act like leaders. We need to train leaders. We need to train good clinicians, but we also need to train leaders who are going to solve problems. And fortunately, there's lots of problems to be solved, and so lots of opportunity. And so I'm very encouraged. We are very, very privileged to do what we do. The impact that we have on people's lives, I think we take for granted our job satisfaction that many, many people, I saw a statistic, 80% of people don't like their job. And we wake up every day and get to do what we love. Yeah. And we would probably do it for free. And we also are well compensated for that. And so now we have an obligation to give back and to help our respective healthcare systems address some of the challenges that they face, with the ultimate goal of improving the health of the population that we are charged with helping.
Amazing. Dr. Dulai?
I'm going to go a little slightly different direction, focusing on Canadian orthopedic surgeons. We know that burnout and risk of burnout is very significant. 2 surveys that were done and published, within the last 10 years, but both pre-COVID, showed over 50% of staff orthopedic surgeons and over 40% of resident trainees were either showed significant signs of burnout or were at high risk of developing burnout. Of course, our primary interest is helping patients, but we're not going to do that if we as a group are not helping each other. So, take a moment, look around you, see your colleagues, and, if you're not in the place where you can help them out, at least try and direct them to someone who might be able to, if you start seeing signs of distress, and recognize that, if someone's not doing their best, it might not just be that they're being a jerk or just not wanting to do it, but, they might be going through some hard times. And as we all do, and maybe I'm going to bring the softer and gentler side of peds to this and say, we can be softer and gentler with each other too, right? While supporting each other, working towards the common goal of improving patient health. We also should try and, support each other as a profession.
Thank you. And if people want to learn more about health and wellness or the COA platforms or the AOS advocacy and your value-based healthcare, how can they reach out to either one of you, Dr. Bozic?
I'm very accessible and love to talk to people about these things. We have on, I guess, Twitter is one way, awesome. But email and accessing our webpage at the Dell Medical School at UT Austin or at the AEOS, but we're always looking for like-minded people that want to contribute to the solution. So I would be happy to meet with and talk to anyone. I do twice a week at 7 a.m. on Mondays and Wednesdays. I do mentorship calls. I've done that for 15 years, where I mentor everything from undergraduates to people in their mid to late career. it's a really a rewarding thing for me to be able to give back, because I've had wonderful and still have wonderful mentors throughout my career, and I love interacting with people and helping them navigate their own career path.
Amazing, thank you. Dr. Dulai?
Well, two things I would say. If I'm going to look at all the viewers, that if you are feeling like you're in a bad place or you're in distress, I really encourage you to reach out to someone that you trust, or even to, provincial associations often have physician helplines. Please reach out to those. And there are people who care, and there is help to get you to a better place. And so I hope that gives you hope if that's the place that you're in. In terms of if you're interested in this subject and you'd like to get involved with the COA's mandate to try to work towards programs to promote surgeon wellness, particularly orthopedic surgeon wellness, then please do reach out to the COA, because we are establishing some working groups to we will be establishing some working groups to work on particular guideline development and advocacy efforts towards that, and then they'll direct you to me.
Perfect. Well, thank you again both for your time. It's been an absolute pleasure chatting with you.
Thanks for including us.
Thank you so much.
Awesome.